All right, let's jump right into part 9 of our 2025 Telemedicine Codes Explainer series. Today, we're zeroing in on a very specific, but honestly an incredibly crucial area of medical coding. We're talking about remote assessment codes for non-physician healthcare professionals. These are those essential team members in your clinic who cannot independently bill for evaluation and management, or EM services. Getting this right is absolutely essential if you want to stay compliant, get accurate reimbursement, and avoid those dreaded claim denials.
So the big question we've got to ask ourselves today is this: how do we actually capture and correctly code medical discussions handled over the phone by non-physicians? Think about it. When a patient calls in and spends meaningful time discussing their care with a clinical staff member who isn't a doctor, while that time and expertise need to be accounted for. But the rules governing this, they are surprisingly strict.
Section 1. Telephone Assessment Codes. Exploring 98966, 98967, and 98968.
Okay, so the baseline rule for these three specific codes is pretty simple. They apply exclusively to an established patient or their parent or guardian. That means no new patients here, folks. When a qualified non-physician jumps on a call, the exact code you choose is literally just time-chunked based on the length of that medical discussion. It's a clean progression. Use 98966 for a quick 5 to 10 minutes. If the call runs longer, boom, you step up to 98967 for 11 to 20 minutes. And for those really extended, in-depth calls, you're looking at 98968 for 21 to 30 minutes.
But, there's a catch. There is always a catch. We have this very strict restriction rule that basically bookends the call. And this right here is where coders often trip up and trigger audits. You can't just build these codes in a vacuum. On the front end, the call absolutely cannot originate from a related service provided within the previous 7 days. And on the back end, the call cannot lead to a visit or the soonest available appointment within the next 24 hours. The conversation has to stand completely on its own as an isolated medical discussion.
Section 2. The critical exception in HCPCS G2251. This is a major Medicare billing trap.
Here is the trap you need to avoid. You must absolutely, positively not use 98960 through 9898 for nurse practitioners or physician assistants. I know, they're non-physicians in the traditional sense, but listen, for the purposes of Medicare billing, these specific providers are qualified healthcare professionals. Medicare treats them as physicians, so they do not fall under that standard clinical staff bucket that those 9890 series codes were actually built for.
Which, of course, begs the question. If we can't use that sequence for NPs and PAs, what on earth is the correct alternative when they are handling these brief, remote communications? Medicare still wants to account for the time, right?
Well, the alternative is HCPCS G2251. This code is specifically designated for a brief communication technology-based service, basically a virtual check-in. It's for a qualified professional who cannot report EM services, and it explicitly covers 5 to 10 minutes of clinical discussion. But here is the kicker. It is subject to the exact same temporal restrictions we just talked about. It cannot stem from a related service in the past 7 days, and it can't lead to one in the next 24 hours. Same rules, entirely different code based on who is on the phone.
Section 3. Summary and what's next. Let's wrap up part 9. Let's quickly tie a bow on all of this so you can walk away with a bulletproof coding strategy. Getting this nuance right is going to save you so many frustrating denials. Just remember this stark contrast. Standard clinical staff use the 989 series based on time. But you must leave your nurse practitioners and physician assistants entirely out of those non-physician buckets for Medicare. You route their brief 5 to 10 minute communications straight through G2251 instead. Ultimately, the provider's credentials dictate the code. It really is that simple.
And that wraps up our deep dive into non-physician remote assessments. Make sure you stick around for part 10 of this explainer series. We're going to crack open the broader Medicare telehealth rules, getting into the weeds of status I codes, and exactly how traditional EM codes crosswalk into the telehealth space. It's going to be a good one.
Until next time, ask yourself, how many brief patient check-ins are slipping through the cracks at your clinic right now, or maybe getting billed under the wrong credentials? Keep your documentation tight, secure your revenue, and as always, decode healthcare with Harshal.